It's 2 o'clock, so we're going to begin now. I'd like to welcome everyone and just to let you know that we are delighted to have you here with us for this webinar on Our Children, Our Future, the health and well-being of First Nations children in Manitoba. This webinar is being presented in partnership with the First Nations Health and Social Secretariat of Manitoba, the Manitoba First Nations Education Resource Centre, and the Manitoba Centre for Health Policy. Next slide. Today we are gathering together virtually from many different parts of Manitoba and beyond. Our workplaces and our homes are located on the traditional territories of Indigenous peoples dating back countless generations. Personally, I acknowledge that I am a guest here on Treaty 1, and I begin by paying my respects to the Anishinaabe, the Cree, the Ojibwe, the Dakota, and the Dene peoples who are the traditional stewards of this beautiful region. I also pay my respects to the Métis, as this is the traditional homeland of the Métis Nation. I honor the elders, knowledge keepers, grandmothers, both past and present. Many harms and atrocities were carried out on this land. The effects of these acts endure today. And many harms and atrocities are still being carried out. This land continues to be marred by institutional and structural racism, by the ongoing colonial project, and by oppression. At MCHP, we have a deep respect for the treaties that were made here. We have dedicated ourselves to moving forward in meaningful partnerships with Indigenous communities in a spirit of truth and reconciliation and collaboration. Next slide. This is our agenda for this afternoon. We will have a presentation that will last for 1 hour, given to us by three presenters whom I'll introduce here shortly, Dr. Mariette Chartier, Ms. Leona Starr, and Dr. Nora Murdock. We'll then take a break for 15 minutes and then come back together to have facilitated discussion time. And your facilitators can be identified on your screen by wearing orange shirts. A couple of things that I'd like to note before we begin. We're using WebEx today, which allows you to see and hear the panelists for this session. However, you cannot be seen or heard. We do have the chat function open for you, and we ask for you to use it for questions to the speakers about their presentation, or if you need to flag to us any technical issues. We do have technical support in the background, and we're going to try to assist you as quickly as we're able to. When you do ask a question, please make sure that you have selected everyone so that I can see your question. I will then read it aloud for everyone's benefit. This presentation will be roughly 45 minutes with some time at the end for question and answers, but please feel free to type your questions as they arrive or during the Q&A session. After that, we'll have that break, and then you'll be able to go into your facilitated discussion. We have three esteemed presenters this afternoon whom I'd like to introduce. Dr. Mariette Chartier is a senior research scientist at the Manitoba Centre for Health Policy, and she's an assistant professor in the Department of Community Health Sciences. Her career extends from clinical nursing, mental health research, early childhood policy development, and population health. Her research interests on prevention and early intervention programs for children and their parents, mental health promotion, child abuse and neglect, perinatal health, health risk behavior, and health of vulnerable populations. She has published extensively in the area of mental health and early childhood development, as well as in prevention and intervention programs for children. With First Nations partners, Dr. Chartier is currently leading a Canadian Institutes of Health research study looking at school-based mental health promotion strategies for First Nations youth and overseeing a report on the health of First Nations children in Manitoba. We also have Dr. Nora Murdock, who is initially from the Mississippiwik Grand Rapids Cree Nation and is also a member of the Fish River Cree Nation. She has dedicated over 30 years of her career to education. Dr. Murdock was involved in the development and implementation of the Manitoba First Nations School Program, in which First Nations exercised their treaty rights to education by working as a collective. She is the Director of Instructional Services in Manitoba First Nations School System. And we have Ms. Leona Starr. She is a Cree woman from Thunderchild First Nation, Saskatchewan, within the Treaty 6 territory. She works as the Director of Research for First Nations Health and Social Secretariat of Manitoba. Leona is a strong advocate of First Nations self-determination and research, grounded in the First Nations principles of ownership, control, access, and possession, otherwise known as OCAP. She has followed the Regional Health Survey model and framework to ensure the highest standards of First Nations research and ethics are upheld in all research projects that include Manitoba First Nations. She has worked collaboratively locally, regionally, and nationally to ensure research and information is governed according to protocols defined by First Nations. Leona works with FNHSSM, the First Nations Health and Social Secretariat Research Team, to provide support to Manitoba First Nations Ethics Review Committee called the Health Information Research Governance Committee. And with that, I will turn it over to the presenters.
Okay, good afternoon to everyone. Thank you for being here this afternoon and for taking the time to be part of this virtual meeting. Thank you, Nathan, for that introduction and for acknowledging the territory. I have the great pleasure of introducing the first few slides of our presentation this afternoon. I want to acknowledge my co-presenters, Leona and Mariette. And also on this first slide, the beautiful painting by Jackie Travers, well-known Indigenous artist. So just want to acknowledge that first of all. So the title of our presentation is Our Children, Our Future, the Health and Well-Being of First Nations Children in Manitoba. So we have a few slides and we're going to take turns presenting here. So just right off the hop, please note materials in this presentation is preliminary and confidential and is not for distribution or discussion until the final report is released, which will happen later in the fall in November. So you can look forward to the report release at that time. So I'd like to present our project team. As Nathan mentioned, partners are the First Nations Health and Social Secretariat of Manitoba, the Manitoba First Nations Education Resource Center, which I work for, and also the Manitoba Center for Health Policy and the University of Manitoba. So I won't name every person on this list, but just to say that every single person here has unique talents and gifts that contributed significantly to the report, and it's a great team. And I just want to say the partnership was very meaningful, and I really enjoyed the relationship building and the partnerships being very real and not just token or anything like that, but just very real partnership. And it was a joy to work with each person on this team. So I acknowledge the people who are on this list. So the purpose of the First Nations Children's Report is to provide a baseline measure of how First Nations children in Manitoba are doing in 2016-17. Yes, this report has been a few years in the making, but well worth it. And it's never a good idea to collect data for data collection's sake, but to ensure that the data and information collected is being used for planning and decision making, and also for future comparisons to determine if children's lives improve over time, which should be the ultimate goal for sure, and to use the information in a meaningful way and not just to have the numbers and the data sitting there, but to use it to improve children's lives. So right from the beginning, when the partners first met, we had a meeting to discuss the indicators that would be used as part of this project. And we knew, all the people in that room that knew that the indicators would show deficits, and we didn't want that to be the focus. And we want people to know, the audience to know, any persons who read this report, that First Nations exist in this country of Canada, in this province, in this city, in individual First Nations, that First Nations children have been disadvantaged historically and continue to be currently in a multitude of ways because of a variety of factors. And it is no fault of their own that the indicators are showing less than encouraging results. And it's because of colonization, colonial laws, policies, and practices in the past and currently. And Nathan did mention some of these, and we have to acknowledge that this continues. And also, we can't forget the impacts of the residential schools and the trauma and the intergenerational effects of residential schools. As Nathan mentioned, I've worked in First Nations education exclusively for the past 30 years or more. And I have to say that, you know, when we work in schools, that we can see the impacts every day, you know, and those, we can't really forget about those, that it continues to impact children because of, you know, the parents and grandparents and what they experience in residential schools. So I just want to acknowledge the survivors and all the work that has been done in that area. There continues to exist economic inequalities in our First Nations communities, and even with the First Nations who live off reserve, that there continues to be economic inequalities. And there continues to be systemic undermining of community autonomy. And also, we all know that the rates for housing shortages, incarceration rates, the number of children in care, high school dropout rates, all those statistics we know are less than encouraging, and they show disparities for our First Nations in Manitoba. So we just want to make sure that we are aware of these factors, and also the continual undermining and devaluing of cultural, linguistic, and traditional knowledges that continues to happen today. But having said all that, I want to say that that it's not all bad. You know, that there's a lot of institutes and institutions and organizations and persons and individual First Nations who have done a lot to mitigate some of these factors. And there are a lot of success stories, and we need to keep our ear to the ground and to know that there's a lot of success, a lot of successful programs. And when we talk about resiliency, we know that First Nations are resilient, and they continue to work with their partners to mitigate some of these factors. But we have to acknowledge that they continue to exist. And as we read the report and look at the data, that we keep all of these things in mind. So I also want to acknowledge the Truth and Reconciliation Commission, the 94 calls to action to redress the legacy of residential schools and advance the process of reconciliation. That the calls touch the lives of children in the areas of health, child welfare, education, and justice, among others. Specifically call number 19, which states we call upon the federal government in consultation with Aboriginal peoples to establish goals to identify and close the gaps in health outcomes between Aboriginal and non-Aboriginal communities, and to publish annual progress reports and assess long-term trends. So our hope is that this report addresses that call to action, and it will be a basis for meaningful change. Okay, next slide. Previous, okay, this one. Okay, in terms of the study process, in the summer of 2017, relationships building between the First Nations partners and the Manitoba Center for Health Policy. So as Nathan mentioned, co-PIs include Leona, who represents the Manitoba First Nations Health and Social Secretariat of Manitoba, and MFNERC, the Manitoba First Nations Education Resource Center. I'm just reading out the whole thing because some of these acronyms get people confused, but MFNERC is the organization that I work for. And the preference for strength-based indicators. And in the fall and winter 2017, all approvals from ethics and data providers to link data, including Health Information Research Governance Committee. And in February 2018, Assistant Deputy Minister's meeting. In March 2018, a presentation was given to the First Nations health directors. And in November 2018, April 2019, and May 2020, meetings with the knowledge keepers, elders from 5 Indigenous linguistic groups in Manitoba. I just want to take the time to acknowledge the knowledge keepers who provided the direction and the guidance and their invaluable wisdom to the project all throughout. And I can't express enough appreciation to the knowledge keepers who gave so freely of their time, and their knowledge and their input is so valuable and is threaded throughout the report. And working with the knowledge keepers is a real honor and privilege to know them and to learn from their wisdom and incorporate it as part of this report. So I just want to make sure that we acknowledge and express our appreciation to the knowledge keepers who were involved in this project. Okay, in terms of the methods, there's 2 groups of children that are part of this report. Registered First Nations children living in Manitoba, 0 to 19 years, who are listed in the registry from the federal government. And then all other children, which includes non-registered First Nations, Métis, and all other children living in Manitoba. And each of the 43 indicators was examined in many ways: by tribal council areas, by on-reserve and off-reserve, by health regions, by all other children, and by income quintile areas. So just reading that last bullet there, I didn't know what quintile meant, even though I've been involved in research. So I've just appreciated learning from the researchers from the University of Manitoba and them sharing their knowledge, and for me getting more familiar with the research and just being part of this project was a real honor. So I'm going to pass off the presentation to Mariette, who will talk about the results, the real meat of this project. And Mariette, it's your turn. Thank you very much.
Thank you very much, Nora and Nathan, for introducing the report. I need to just say something on a personal note before I kind of dive and get all lost in this data, but it has been an honor and privilege for me to work on this team with the knowledge keepers and with everyone that has worked hard on this report. I have to say, though, that it's been very disheartening to see the gaps in outcomes that you'll be seeing soon between First Nations children and other children in Manitoba. It's been said, though, that what gets counted counts. And so it's really our hope that all the counting we did during this report and sharing with you today will make us all double our efforts to address the gaps. So with this, let's immerse ourselves in the results. So what we have here is, Nora just mentioned, how did we make up, what made up our study, who was in our study. So First Nations children made up 18% of Manitoba's child population. So that there was 61,700 kids in our study. There were 40,416 who lived on reserve and 21,310 who lived off reserve. And then all other children in Manitoba, there was 279,087 children. So these are what you'll be seeing are the indicators are related to these kids. We thought first that we would just get a big picture and look at the age and sex profile of all Manitobans. So the First Nations, all First Nations are by age group here, and they're the light blue lines, and all other Manitobans are the white lines. And it's just to show that close to 45% of First Nations population are 19 years or younger. So we have that down there. And we see that 25% of all other Manitobans, that makes up the percentage of the child population. For indicators, we know that there are many, when we're trying to figure out what are we going to look at, this report was on the health and well-being, and we knew that there are many factors that influence the children's health and well-being. So this is what influenced our choice of indicators. So we looked at birth outcomes, physical and mental health, and mortality. We looked at social services, family services, education, justice, and healthcare. So we looked at many different types of indicators, that all aspects that influence children's health. So let's start by looking at healthcare and prevention services. These are for all Manitoba children, 2016-17. The first column in these tables will all look the same. So the first column are all First Nations children, so the 16,000 children, and all other Manitoba children are in the second column here. When something is bolded, it means that it's statistically significantly different. So for hospitalization episodes, we see that the First Nations rate, it's by per thousand, is much higher than all other Manitoba children. No difference in the number of drugs that were taken by the children or medications. It's not bolded, so not different. And the complete vaccination rate at age 2 is lower for First Nations children. Nora mentioned that we looked at indicators in many different ways. And these are the regional health authorities, and we thought it was important to show them by regional health authorities because children living off reserve obtain their services through health regions. So here's an example of what it would look like in the report. This is taken exactly from the report. And these are hospitalizations by health regions. So here we have all the health regions, and here we have the Manitoba rate overall. The very top line, it's kind of on my screen anyway, a pale gray. This is the rate for hospitalization rate for First Nations living on reserve. The next one is a dark or a green bar. These are for First Nations children living off reserve. The next bar is a mixture, so it's the whole group, the 61,000 kids. And then the last bar are all other Manitoba kids. So what we see is, to sum up, is that across all the regions, and you can tell by the 5 here, it's telling us that there's a difference between First Nations children and all other children. And we see that that's the same throughout all the regions. There's no differences between children living on reserve and off reserve, though, in some regions it appears to be, but it's not statistically significantly different. And the story is the same across all regions. Here are the birth outcomes that we looked at. These we feel quite confident in sharing because it's data from hospital data, where most of the births occur, not all, but for the most part, births occur within hospital. And the first column shows us First Nations rates for First Nations infants and for all other Manitoba infants. We see that for preterm births, there are a higher percentage of First Nations children who are born prematurely than all other Manitoba children. For small for gestational age, we found that it was kind of the opposite, so that it's not good to be born small for your gestational age. And for First Nations children, there's a smaller percentage of them that are born smaller. But we need to look at that with the context of large for gestational age, which is not good either, and is often due to high rates of diabetes. We know that First Nations women have high rates of gestational diabetes, so that on average, most kids are born larger. Breastfeeding rates are lower for First Nations infants. Teenage pregnancy and teenage births are higher, and newborn readmissions are higher. Nora mentioned that we looked at the indicators by tribal council areas, and the knowledge keepers told us that this was very important because tribal council areas are where services are often offered for First Nations children and people living on reserve. So here's an example of that. These are breastfeeding rates by tribal council area. So here's all the tribal councils. Non-affiliated, there were 2 First Nations who aren't affiliated with the tribal council, so we put their results under non-affiliated. What I want to show you, oh no, I'll show you something else first. There's a double S here, and this tells us that, for instance, interlake reserves, their on-reserve rate is lower than their off-reserve rate. So the green line is off-reserve and the light blue line is on-reserve. And we see that this is true for quite a few of the tribal council areas. We also wanted to compare the different tribal council areas, not to compare, it's not a competition, but more to learn if, for instance, we noticed that Independent North has high rates or relative high rates of breastfeeding. And what we did is we compared other tribal council areas to Independent North. They became our benchmark. And the idea was that the tribal council areas could compare notes and learn from each other. We see if there's a dagger beside the tribal council, it means that their rate is lower than the benchmark. If there's a double dagger, and there's only really one in all of these, it's telling us that the off-reserve rate is lower than our benchmark for Independent North. So I know it's a bit complicated, but there we have it. We look where take a look at where women are giving birth. So these are this is a finding for First Nations women living on reserve, and we found that nearly 1/3 of First Nations women living on reserve have no year-round access to services to assist them with giving birth. And this has implications because it means that they need to fly out of their communities, be away from their families and their communities with minimal supports often, and also, you know, just needing to the high costs of transportation as well. We looked at social services for First Nations children and all other Manitoba children. You'll notice everything is bolded, meaning all of these are statistically significantly different. Children in care, rates of children in care are higher, much higher for First Nations children compared to all other Manitoba children. These are all percentages. Families, First Nations families are more likely to be involved with child and family services. They're more likely to be receiving income assistance. When the youth leave their families, 18 and 19-year-olds are more likely to receive income assistance compared to other Manitoba youth. And families, First Nations families, are more likely to be living in social housing. These results are from the Department of Families. So that's where the data comes from. The third way that we looked at the data is by looking at income quintile. Now, income quintile, at Manitoba Centre for Health Policy, we often look at indicators by income quintiles, and it's well recognized that people who are living in areas of lower socioeconomic status have usually more adverse outcomes. So we thought, well, let's compare to those in the lowest income quintiles and those in the highest. Highest would mean that this is where we could actually achieve those rates because some people in our society have. And so this is the percentage of children in care for First Nations. So the First Nations results are at the top here by urban off-reserve, so Winnipeg and Brandon, rural on-reserve, and rural off-reserve. And what we see is that even if then we compare it to all other Manitobans. And we see that for all other Manitobans, it is true that those living in the lowest income quintiles do have higher rates of children in care. But what we found is that even when we compare to the lowest income quintiles, First Nations children are taken into care at higher rates than other children in Manitoba. For mental health indicators, we looked at several of them, and this is data from physician claims and from hospitalization. So these indicators are dependent on a child or a youth seeing a physician to get a diagnosis. And what we see is that so we see that all except one indicator are bolded, meaning it's statistically significantly different. There are higher rates of ADHD among First Nations children, no difference in mood and anxiety disorders, higher rates of substance use disorders, so addictions really, higher rates of schizophrenia, higher rates of hospitalizations for suicide attempts, and higher rates for completed suicide. And these rates are astronomically higher, like more than 10 times higher. It's curious that we have, usually when people take their own lives, it's because they're suffering from depression. And it's very curious that the rates of depression are the same as for all other Manitoba children, but the rates of suicide are higher. So when we talked about this with community members and knowledge keepers, it was pretty clear that there is a lack of mental health services or culturally competent mental health services. I wanted to just show you the prevalence of schizophrenia because it's a very difficult illness, and it's usually supposed to be. Usually, you see the rates are similar, across all kinds of all layers of society. But here we're finding that there are high rates among First Nations people, and that is telling us that. This really should be looked into why that is going on, because it is a severe illness and is once it starts, it's very difficult. It's treatable, but it's a very serious illness. What's interesting is that there is no difference across the health regions, and there's no difference between on and off reserve. We looked at physical health indicators. As with mental health indicators, these are based on physician claims and hospitalization. So the children have to see a physician or a nurse practitioner in order to get a diagnosis. And that's important because we found that some of these indicators, it's a bit of a mixed bag. So, for instance, asthma has a lower rate. First Nations children have a lower rate of asthma than all other Manitoba children. Diabetes is higher, much higher. Dental surgeries are very much higher for First Nations children. There are higher rates of lower respiratory tract infections. But otitis media, which is a fancy word for middle ear infection, the rate is lower among First Nations children. No difference in eczema or atopic dermatitis, and higher rates among First Nations children for developmental disorders. When we asked about this in general, the feeling from knowledge keepers and community members was that primary care is access to primary care is not always there, and could explain the inconsistencies we're seeing in some of these diagnoses. This is, again, the prevalence of diabetes by income quintile. These are the rates for First Nations kids, and these are the rates for all other Manitoba kids. And what we see is that First Nations children have higher diabetes rates than all other children in the lowest and highest income quintiles. Child mortality, we looked at 3 indicators. Child mortality is used across the world to determine the health of a population. And so what we see here is that infant mortality, so those are, children that are not 1 year old yet, the rate looks higher among First Nations children, but this was not statistically significantly higher. For the child mortality, these are children from 1 to 19 years old, and it is much higher among First Nations children. And there are higher rates of stillbirths among First Nations children. Here's a closer look at child mortality by health region. And what it's telling us, that the 5 tells us that there's a difference between First Nations children and all other children. And we see that all health regions, except Southern Health, there's a higher mortality rate among First Nations children. There is a 6 beside the Manitoba rate, and that tells us that the rate is higher on reserve than off reserve. There's no 6 there's no 6 beside any others, which tells us that for other regions it's not different. We looked at educational indicators. I think we looked at almost all of them because Nora was on our team and wanted to see all of them. And so these are, they're, I guess, in a way, positive indicators in that a higher percentage means it's a good thing. It means that, for instance, grade 3 assessments, that the children are meeting or approaching expectations. These are all statistically significantly different. And unfortunately, again, what we see is that children for grade 3 reading assessment and numeracy, mathematics, student engagement, grade 3 reading and writing, they're less likely to pass their language arts and mathematics tests and less likely to graduate from high school. These are, I must say that these are from the Department of Education, and we're fairly complete. As years have gone by, First Nations are providing data to the Education Department. We did have discussions in our groups about culturally appropriate assessments, and that is something that we likely should discuss in our discussion groups. Nearly twice as many First Nation students are no longer engaged by grade 7 compared to all other Manitoba students. Here again, we're looking at First Nations children, comparing them to all other children in the lowest income and highest income areas. And what we see is that First Nations children, it doesn't matter if you're comparing them to the lowest or highest income quintiles, have lower rates of high school graduation. Finally, here are what we looked at for the justice system involvement indicators. We looked at accused of a crime, victim of a crime, and being a witness to a crime. These are percentages, and First Nations children have more justice system involvement on all 3 indicators. To look a little bit closer at the percentage of adolescents accused of a crime, we looked at them by tribal council areas. We noticed that there's no double S's, so that means that the on-reserve and off-reserve rates are essentially the same. And we also noticed that there's some daggers besides some of the tribal council areas, and that's telling us that on-reserve rates are higher than Island Lakes. Island Lakes was our benchmark in this case. So yes, Island Lake had the lowest on-reserve rate, and there was no difference in rates between on and off reserve, and no differences across tribal council areas for children living or youth living off reserve. So to summarize, we found large disparities between First Nations children and all other children. Children living off reserve generally fared better than those living on reserve. And I mentioned this as we were showing the results, but one of the limitations is that there likely is some underreporting of the medical conditions because children need to see a physician or a nurse practitioner to get a diagnosis and show up in our data. I tried to refrain from doing too much interpretation because I wanted to leave the floor to Leona to do that for us on behalf of the team. So Leona, I will pass the mic to you and I will mute myself.
Thank you for that, Mariette, and thank you for the introductions, Nora, and providing that historical context in terms of the impacts of colonization. I want to first bring it back to what we heard from our knowledge keepers during our various meetings with them, not only on this project, but in projects previous to this, in terms of really coming from a place of strength. And I know it's hard to see those strengths within the limitations of the data we had available to us. I just want to remind, I guess, our attendees today, as First Nations people, our children have had rights as they have been given to us by Creator. Our children have the right to their name, not their English name, but their spiritual name. Everyone is born with the spiritual name. And it's just reigniting that memory. Every child has a right to their clan, to know their clan. Every child has a right to be with their family, to live with their family. And every child has a right to practice their culture and ceremonies, regardless of where they reside. Every child has a right to their identity, to know who they are. Every child has a right to practice their language and to speak their language and to have access to their language. Every child has been born with a purpose. We all have. Every child has a right to their ancestral lands and territories. They have rights to live within the lifestyle of their people. We have a right to our own education systems and laws that have provided for us since time immemorial. Every child has that right to be protected within and outside of their family. And as families and as parents, we have roles and responsibilities that were given to us to ensure that these sacred beings are protected throughout their lives, from the time that, I guess that sacred time when as women, we carry that life, as that sacred time when we give life. We're a vessel for that sacred transfer of that little being, that sacred spirit from the ancestors. Next slide, please. However, throughout history, we've had interruptions based on colonial acts that have left its legacy on the spiritual, physical, and emotional well-being of our children. I'm not going to go through all of these acts. As individuals who do that work for the children, I challenge each and every one of you to become familiar with these acts in terms of really recognizing it and acknowledging the harms that exist today and continue to exist within these, within the laws and policies of today that currently govern our justice system, the acts within the children that are imposed upon our children and the lives of our families, that allow for the removal of our children, that allow for the assimilation of our children into a Western context that we were never born with. It really violates those rights that our children have been given by the Creator. Next slide, please. And just going back to this statement to kill the Indian in the child, and what a legacy that has been and continues to be. Because from a place of strength and well-being, there's been targeted acts of violence against our children through the forced removal of our children from our communities, that left our communities without children, and what that has done to the family structure, and why we see these high rates across various analysis that we showed within this report. And every time I hear the stats coming from this report, it doesn't make it any easier. It actually makes it really hard to listen and hard to hear. So when we talk about colonial acts that have existed but still exist today, as Nathan had alluded to earlier on, until these acts are corrected, until these acts have a place, create space where us as First Nations people take back control over the lives of our children, create that space, that safe space where our children will live and thrive in. We'll continue to see this gap between our children and all other Manitoban children widen, as we've seen with other various reports. Next slide, please. And in keeping with the messages of our knowledge keepers, because I know even for them, going through the report, it was heartbreaking. Because we know as grandmothers, as mothers, as families, as fathers, aunties and uncles, we have failed. We have failed to protect that sacred life that we've been given a responsibility for. We have failed to have that sacred bond amongst our families intact due to those colonial acts of genocide. Those colonial acts that have forcibly removed our children and separated our families from one another. What we've been told by our knowledge keepers is to be able to return to the land, return to a natural diet that has reconnected to our spirits, to remind our children and ourselves that we are here for a purpose, and how our children must be taught within our own sacred laws and natural laws and responsibilities, and how that promotes education and lifelong learning, which starts within the home. And oftentimes we see our children who are often removed from our homes, not because we don't love them, not because we don't care for them, but because of imposed poverty that has been put in place through decades of colonialism and racism within systemic practices that are held today and continue to be. And through interventions like MFNERCs to take control back of our education systems, to create space where our own people are actually in those places where we're effectively teaching our young children how to instill that pride and then instill that identity, to instill that spirit back within them. We'll continue to see that gap widen. Next slide, please. In terms of listening to the knowledge keepers, in terms of repairing that sacredness of birthing and parenting, being able to have the resources and supports to be able to facilitate the safe return of our children back to our home fires is a necessity. And programs supporting the inclusion of supports right from prenatal to adulthood is necessary. And the fact that our grandmothers, aunties, and mothers must be included to bring balance back to our families and to celebrate those rites of passage that everyone has a right to celebrate that shift from childhood to adolescence, and those sacred ceremonies that go along with those practices, they need to be celebrated, they need to be brought back. Those teachings need to be returned and instilled within our families and our young ones. Next slide. And I think with that, I know we're cutting it pretty close in terms of time, but I didn't necessarily want to cut off the messages from the knowledge keepers, and I just really appreciate this relationship with the Manitoba Centre for Health Policy, as well as the Manitoba First Nations Education Resource Centre, and really listening to the advice provided by our knowledge keepers, because they have, where as a team, I know we're internally grateful for the time they've spent in terms of guiding us in this work. I guess so.
Thank you to all three of you for that very powerful and presentation. There was some questions that came in during the course of the talk that I wanted to circle back to, and for those participants who might have additional questions now, I invite you to post them into the chat window. Just a reminder to make sure that your indicator identifies everyone so that I can read your question out loud. Earlier on in the presentation, there was a question posed that asked if you could talk a little bit more about which communities were included in the Independent North. I'm not sure who would be best to take that question.
We kind of followed suit with the analysis that we undertook with the First Nations Atlas. And we included the independent northern communities as those who were unaffiliated with tribal councils at the time of the analysis. So in terms of seeing a list of who those communities were, in terms of identifying them within that analysis, I believe that list is also included within the First Nations Atlas. That is already publicly released as of last fall, because this report isn't actually going to be publicly released until November, as Nora had identified.
Thanks. Another question that was asked is whether your team was able to look at any cardiac conditions amongst children.
I mean, I can, all of us can answer that. We had lots of discussions and, you know, a lot of hand wringing about what are we going to look at. There are so many things, you know, I think as we alluded to this morning. So we had to make some choices. We did not look at cardiac conditions in children. It might be a little bit difficult anyway, because thankfully they're quite rare, but we did not.
Great. A follow-up question, another question was posed. It's really curious that the schizophrenia numbers were so similar, and the attendee is wondering whether this might have anything to do with the ease of access to cannabis, because there's been documented correlations between cannabis use and schizophrenia.
Does anybody want to take that? I mean, I can address it a wee bit, and Nathan, you probably can too. For a while there, I worked in psychiatry for quite a long time, and for a while we thought, you know, schizophrenia was just genetics, right? It's, you know, if it was in your family, you know, you'd have a higher chance of getting it. But we realize now it's more complicated than that. And while the link, but it's kind of hard to see, to really determine for sure the link between cannabis and schizophrenia, there seems to be a growing body of research that says that cannabis can put people predisposed to schizophrenia at higher risk of expressing that gene. But I don't know, Nathan, do you want to add to that? Because you've looked at that as well.
Just a little bit that it's, yeah, the high potency cannabis that increases, that's been documented to have a correlation between cannabis use and schizophrenia. I think that this is definitely an area of research that needs to be done for the province here as cannabis, non-medical cannabis use has become legal. I don't know if anyone else on the team has any comments about that. There's been other questions that have been coming in the meantime.
I noticed that Denis Fortier has something to say about the schizophrenia.
Yep. So Denis says that genetics for sure, but this is an unresolved intergenerational trauma that might be a factor. All the more reason, if true, to heal the trauma. Earlier question that was raised is wondering if the team could speak to how access to birth services was measured, and is it a minimum distance from the home community?
Do you want me to? So we used, it was a measurement, and it was a measurement used by the federal government. It was suggested to use this. Wanda Phillips-Beck and Rhonda Campbell thought that this might be a good way to do it. So there's 4 different zones, needing to travel 50 kilometers, 50 to 350 and over 350. And then zone 4 was a fly-in community. So we used these, I guess, this measurement used by the federal government. Does that answer your question?
Not seeing her. Yes, it does. Thank you. We have time for maybe 1 or 2 more questions before we go to our break. A lot of gratitude being expressed in the chat window for the work that the team did and documenting the health outcomes of children, and so working to move forward for better outcomes for future generations. So thank you to everyone who participated in this project.
I think, Nathan, just one final comment on behalf of our organization is just really stressing the importance of involvement of First Nations as it applies to identifying solutions for First Nations. In terms of having a study like of this magnitude be co-led by our First Nations Educational Institute, as well as First Nations Health Organization, along with allies such as Manitoba Centre for Health Policy, really creating space for that dialogue and creating space for our knowledge keepers to really provide that advice and guidance going forward in terms of what is actually going to solve all these challenges and gaps that we're seeing within the well-being of our children. And they've identified these pathways forward, which, had First Nations not been involved with this report, probably would have overlooked some of those recommendations being provided by knowledge keepers themselves. So the importance of having that relationship from the onset in terms of creating space for that dialogue and that respectful, reciprocal relationship that has been created.
Thank you, Leona. I think that's a beautiful space for us to end our afternoon session together. Just hearkening to the relationships that were so critical to this project. And so I thank everyone for being a part of that, because I know it's a lot of time that everyone devotes to this. So thank you very much. To all of the attendees, we're going to break now for 15 minutes. You should have received a Zoom link if you registered for the following session. You'll go into the Zoom meeting, and then we'll break out into small groups and have discussions about the material that was shared with us by Dr. Murdock, Leona Starr, and Dr. Mariette Chartier. So thank you to the presenters. Thank you to everyone who participated in this webinar, and we look forward to seeing you in a few minutes.